Well, hello. I would like to welcome all of you to the SSR Radiology Resident Education Club webinar. My name is Dr. Hilary Humans. I'm an MSK radiologist based in New York City. I happen to have a particular interest in foot and ankle imaging, so I'm excited about tonight's lecture. I'll be serving as moderator of this session. I'd like to remind you to sign into Poll Everywhere before we start. At this point, it's my pleasure to introduce this evening's speaker. Dr. Chen is a full professor of radiology in the musculoskeletal radiology division at the University of California, San Diego, VA healthcare system in San Diego for 14 years. She's particularly interested in sports medicine, musculoskeletal ultrasound, and rheumatology. A native of Buffalo, New York, Dr. Chen attended the University of Buffalo both for her undergraduate and medical training. She completed residency at both the University of Rochester and Brown University and musculoskeletal radiology fellowship training at the University of Pennsylvania. Okay, Dr. Chen, please take over.
All right. Thank you, everybody, and thank you to the SSR and Soterias for the very kind invitation to talk to you today about commonly missed ankle and foot fractures. Again, thank you, Dr. Humans, for a very, very nice introduction. So over the next couple of about 40 minutes, we're going to kind of go through a whirlwind tour of some of these ankle fractures. I don't have any relevant disclosures to talk about. And to start, I want to tell you guys about the cardinal rules that I have and that I tell all of our residents who start the rotation on MSK with us. So the cases to really be aware of for me, just from experience, is that first case of your shift. So just as you sat down, finally, like the PACS and all of your stuff has like logged in, PowerScribe or whatever dictation software you're using is finally up and running. Be very careful with that first shift because your head's not quite in the game yet. So spend a little bit of extra time with that case and do your best at it. And I think it'll kind of prevent you from having these kind of obvious or so-called obvious misses. The other type of case that I want you to worry about is the one that looks super duper ugly. So if it flashes onto your PAC screen and you have this inordinate desire to close that image and like hope that your co-resident or a co-faculty is going to take that case, those are the cases that I want you to spend a little bit of extra time with again. And plus, you're not supposed to close that case, right? You're supposed to read it. So some helpful habits I think you are probably all well aware of here listed in format here, magnifying and the zoom features on your PACS. One view is no view, prior study, use what's on your screen, satisfaction of search, and also follow soft tissues. We'll see examples of that in this kind of case format as we start. So here's our first case. This is a 44-year-old man who was rushing around cooking dinner for his, cooking the birthday dinner for his wife, and he stubbed his toe on a metal fan. So this is one of the poll everywhere questions. It looks like we've got some green dots popping up in the region of the dorsal aspect of the fourth toe, distal interphalangeal joint. Got a little guy over here too, but I think everyone's pretty much honed in on the abnormal finding here. So this is an example of one view is no view, as the Royals have found out here from these images taken of the prints. And here is the image one more time. This is the 44-year-old toe. And here we can see the flexion deformity, sports flexion on the extended distal interphalangeal joint, leading to the avulsion from the extensor tendon along that dorsal base of the distal interphalangeal joint. Fortunately, this is an easy fix. This toe was buddy taped together, as was the fan here. So that it would prevent any future injuries to any unsuspecting toes. Here's our next case. And this one, I have to say, is a really tough case to see. So trying to find where the abnormality is. I'll give you a little bit of a clue. This patient fell and twisted their ankle and is now complaining of lateral sided pain. So a lot of little dots here, but I think everyone is starting to hone in on the finding here at the cuboid, which is great. So this is an example of making really good use of your magnifying glass. This right hand image here shows the same case one more time, just with slightly better resolution. And even without the magnifying glass, I think you can maybe start to see this subtle lucency along the lateral margin of the cuboid. However, this is seen to much better advantage when we magnify the image and also put that yellow arrow there as well. So you can see that cortical disruption along the lateral margin and with the intra-articular extension extending into the calcaneal cuboid articulation as well. Moving on to this next case, this is an example of the radiologist's best friend. It may or may not be a human. We are quite lonely people and introverts. But if you guys can find the finding here, the history is just chronic forefoot pain. Give a few more minutes. Kind of got some green dots all over the place. I promise it will get a lot easier when we see the radiologist's best friend. And so the radiologist's best friend, as you might all remember, is the old film. So we have the old film on the right-hand side, or the old film, old image, previous study. And we'll see that the bipartite tibial hallux sesamoid is much closer together on the previous examination. And the current study, we see this distraction of both portions of the tibial hallux sesamoid, suggestive of a distractive injury of that sesamoid, leading to the patient's new cause of pain. And we don't work in a vacuum entirely, but a lot of times, our patients are coming to the emergency room without any history, and oftentimes they're wheeled right to the radiology department for their radiographic studies before the patient has even seen a physician. So even if you call the ER provider, you may not even get any good history. So this is a nice example of using what's on the film or what's on the image to help you. And a lot of you are doing just that. So you're seeing and keying into this arrow that's placed by our radiology tech, who is often, chit-chatting with the patient, asking them where their pain is. So you gotta kind of work as a team to kind of try to do your best to find the abnormalities. Here, a higher resolution image showing these small ossific fragments along the dorsal aspect of the navicular cuneiform articulation, corresponding almost exactly to that arrow that was placed by the technologist. Unfortunately, that can bite you in the butt too at some points. This is another case. He's a 77-year-old man whose status post-fall. And the ER provider gave us a history evaluate for a base of the 5th metatarsal fracture. So, as we look at this one more time, we've got a lot of green dots here. Looking at this base of the 5th metatarsal, it looks pretty good. But a lot of you have keyed into some of the findings here. We'll draw your attention to this lucent line here along the anterior process of the calcaneus. So that is the fracture that was identified. Even though their question was base of the 5th metatarsal fracture, thankfully they did not fool us this time, which is a win. This next case is another toughie case, and this is a 74-year-old man with chronic foot pain. And this is a case where, you really have to use all of the things that are on the image. So use your adjacent phalanges to help compare where the where the finding could potentially be. So as we trace out the cortices here, we can see the smooth cortices of the second through fourth and also the first proximal phalanges. I think a lot of you have already keyed into the fifth proximal phalangeal fracture, which is excellent. And here, when I get to the next image, we'll see that fracture a little bit better without all the green pins on it. And here we can see the cortical disruption and also a little bit of impaction right at the proximal phalangeal base, exemplified here by this band of sclerosis in this patient with a subacute fifth proximal phalangeal fracture. All right, SOS. So does it mean save our souls, or is it a cry for help? So a lot of you have kind of filled in and kind of seen the big fracture here at the base of the fifth metatarsal. Ooh, yes. None of you were fooled by this distractor fracture. I'm so proud of you. That's great. This is satisfaction of search. And as you know, a lot of these fractures can happen in a blink of an eye, something so quick, and it can involve multiple directions and lead to multiple fractures and multiple ligamentous injuries at the same time. So as we look at this radiographic image, we again see that minimally displaced fracture at the base of the fifth metatarsal. But for the astute, we also appreciated the mildly angulated fracture at the fourth metatarsal neck. Follow-up image here again shows those two fractures now with healing callus around the base of the fifth metatarsal and also that fourth metatarsal head with a subtle amount of angulation unchanged from that prior examination. The last of the kind of helpful habits that I wanted to talk about is to follow the soft tissues. So as we look at the AP radiograph of the ankle here, we can see florid soft tissue swelling over the distal fibula without any appreciable fracture. We'll notice this little ossicle here and just kind of chalk it up to the sequela of remote trauma. As we turn to the mortise view, now we can see not only the soft tissue swelling, but this thin linear density just paralleling the surface of the distal fibula. This patient ended up getting an MRI shortly after that radiograph, and on the T2 and T1 coronal and axial images, we can start to appreciate the stripping of the periosteum as this band of low signal intensity extending along that distal fibula. Harder to see on the axial images as this kind of blurred periosteum or kind of this low signal intensity here. You may wonder about this distal fibula marrow edema, but that is really just a part of our inhomogeneous fat suppression on our ankle MRI. If you still didn't believe me, this patient fortunately had a prior MRI as well before that fall. And here on the prior June 2020 images, again, coronal and axial T1 and T2 fat suppressed images, you can see that the periosteum was really nicely closely applied to the distal fibular bone surface. And again, we're having that inhomogeneous fat suppression along the distal fibula as well. Because the MRI was not enough, we ended up imaging this patient with ultrasound as well. And it's amazing how it is so much more easy to see that little fragment of that stripped off periosteum here as this hyperechoic focus on the ultrasound image. Looking at the surface of the fibula as well, you can see how irregular it is, and that is as a result of it being pulled off from that fibular surface. On the right-hand side, what we're looking at is the dynamic images of the Peroneus longus and brevis tendons with ankle circumduction. Remember that the peroneus brevis is located closer to the bone and has the muscle belly. So it's this little guy right here. And the more superficial is the peroneus longus. So as we watch the peroneus brevis, we can see that it's subluxing underneath the area of the stripped off periosteum as a result of this injury. So it is important to remember the superficial peroneal retinaculum as the primary restraint to subluxation and dislocation of these peroneal tendons, typically injured in the setting of dorsiflexion and also eversion injuries. So don't get alarmed by all of these diagrams, but Davis et al. In 1994 looked at many cadaveric specimens and found that there is a lot of variability of the superficial peroneal retinaculum. And where the variability is its posterior attachment, whether to the Achilles tendon or some adjacent soft tissues or even the calcaneus. But what is tried and true is its attachment onto the distal fibula. So this is about the same in all of these cases. And this is the area that is in question that stripped off the periosteum in our case. So we're going to switch gears a little bit and start talking about some of our midfoot fractures here. And again, using this case as an example, we start to see the soft tissue swelling along the dorsum of the foot, which helps clue us into this tiny, tiny fragment here. Looking at the oblique and frontal radiographs here, we can see even more fracture fragments at the tarsometatarsal joint and arising from the medial aspect of the navicular as well. This patient ended up getting an MRI, and we can nicely see on these axial images the rupture of the tarsometatarsal capsule here as this floppy, low signal intensity band-like structure. In addition to that, we have all this edema within the base of the first metatarsal and extending also involving the second metatarsal base as well. Peeking through here, we start to see some of the Lisfranc ligament here on this subsequent slice as well. The edema becomes even more pronounced, involving the bases of the first and second metatarsal. And as we progress towards the plantar aspect, we start to see even more edema involving the medial cuneiform and the second metatarsal base. This last image here shows even more portions of the Lisfranc ligament and also some more edema in that third metatarsal base now. So that brings us to this question. And we're kind of frozen on this last of the images here, which is true. So we have a couple choices here. Lisfranc proper is torn, Lisfranc plantar is torn, Lisfranc plantar is sprained, and Lisfranc proper is sprained. All right, so we have so far Lisfranc plantar is sprained, none of the above. So we're going to keep watching this. I'll give it a few more seconds. All right. Oh no, it's tough because there are so many images there. So we've got if we go back, the right answer was you should have gone with your gut. Everyone was we were doing so well, but the answer was C, which is Lisfranc plantar is sprained. And if we go back, let me go back a little bit. So this is the Lisfranc proper, which is actually intact, but there's a lot of surrounding edema, which may have made it a little bit more suspicious that it might have been sprained as well. But the fibers there are intact. And then moving towards the plantar portion of that Lisfranc ligament, we can actually see that there are some intact fibers, but it is indeed very kind of nebulous and kind of shaggy looking, so that it was a sprain of that plantar portion. All right, moving to talking about these Lisfranc injuries. As we all know, this is the Lisfranc is the fracture and dislocation that we do not want to miss. because it is fraught with so much liability. And this was just taken from, the website of Miller and Zois's law firm. And, these add up, all of these numbers: past medical expenses, lost wages, future lost wages, non-economic damages. So, this is what we are most afraid of. So how do we do? Rankine et al. In 2012 looked at how well we do assessing for these Lisfranc injuries with their conventional radiographs, and they found 69% were identified correctly on radiographs alone, leading to the positive predictive value of 84%, 53% negative predictive value, and the sensitivity of only 84%, and a specificity even worse at 53%. So I know we're all physicians. None of our parents would have been happy with this if we brought home a test that said 70% or 69%. So what does this mean? Well, we're going to have to work a little bit harder to find them, and we're going to have to rely on some other, modalities to help us make these diagnoses. This is a nice example of a patient with a homolateral type Lisfranc fracture dislocation, and what can potentially happen if the patient keeps walking on it. And of course, sometimes we can't control what the patient does afterwards, even though this was diagnosed, at the time of initial radiographic examination. We can see the offset of the first metatarsal with the medial cuneiform, as well as this fracture at the second metatarsal base, and the offset of the second and third metatarsal bases with respect to them intermediate and also the lateral cuneiforms. Here's a normal foot here, which I drew some of the lines that we kind of will kind of judge our alignment by. So in general, the first metatarsal will need to be lining up with the medial cuneiform, whereas the second metatarsal with the intermediate, and the third with the lateral cuneiform, and for the fourth and fifth, lining up with the cuboid. And of course, you want to make sure that these are weight-bearing radiographs, such that you have the best chance to detect these subtle alignment deformities. This patient, unfortunately, did not heed their doctor's advice and kept on walking on their foot, probably because he has an insensate foot as well. So even after the syncopal fall, he continued to walk on it, and then we see that progression of that homolateral Lisfranc fracture dislocation, now with even more lateral displacement of the forefoot with respect to the midfoot. He ended up getting a CT, which really nicely shows that, the conventional radiographs are going to just be showing you the very tip of the iceberg of the number of fractures that are going to be present in these fracture dislocations. Already, we can see the second metatarsal base fractures, but we see a bunch of fracture fragments in and around the tarsometatarsal joints, complete obliteration of that cuboid as well. And I wanted to draw your attention to these fracture fragments kind of in these little cubbies along the lateral margins of the cuneiform, to indicate that these are some sites for ligamentous attachments as well. So I'm going to move away from talking about just the Lisfranc ligament itself, but understand that there is a Lisfranc ligamentous complex. And this diagram is very, very complicated, but it's meant to just to remind you that there's just more than one. And we've kind of labeled the metatarsals as such, M1 through M5, and the cuneiforms C1 through C3, and then we labeled the cuboid as the C4. So when we talk about these ligaments, we can talk about, the Lisfranc ligament C1 to M2 being torn, or C1, C2, M2. So it becomes a little bit like this fabulous game from my childhood, Battleship. But this is purely just to make sure we try to be as accurate as possible of what ligaments are damaged and what needs to be done to help kind of preserve the foot. As we go through some of the anatomy here, this is the Lisfranc ligaments in short axis on both the cross-sectional MR image as well as the cadaveric section from this article in 2010 by Castro et al. You can see the proper portion of the ligament as this low signal intensity structure kind of in between the bases of the cuneiform and the second metatarsal. And the plantar portion here as this wispier band denoted here by the white arrow as the plantar portions. This asterisk is denoting the Peroneus longus tendon in cross-section as well. So now that we've seen it in cross-section here, this is what it might look like at the time of axial imaging. These kind of band-like fibrillar structures on both our fluid-sensitive and T1 weighted sequences corresponding with this glistening proper Lisfranc ligament. And then this is the plantar portion, which I wanted to remind you has like two kind of two arms to it and shaped like a little bit like a Y. So connecting between the medial cuneiform and the base of the third metatarsal as seen here, as well as from the medial cuneiform and to the base of the second metatarsal as seen on the right side image. More dramatic Lisfranc fractures include this divergent Lisfranc, where we can see that the first metatarsal and the remaining lesser metatarsals are going in opposite directions. This is typically high energy trauma. In this particular case, it was a woman who fell from 4 stories. We have fractures of the medial cuneiform and also at the cuboid as well. So I don't think this is one that would be easily missed. However, this is one that is potentially going to be one that we'll miss. And we can see why that could be on the right-hand image. When we look at the oblique radiograph, all of the metatarsals are kind of lining up as expected, the second with the intermediate cuneiform, the third with the lateral cuneiform, the fourth and fifth with the cuboid. But when we turn to this weight-bearing radiograph, we can see that widening between the second metatarsal base and the medial cuneiform, suggestive of this ligamentous injury. The corresponding MR here shows, again, edema within the expected location of the Lisfranc proper. Here also on the axial images, and into the plantar portions of the ligament as well, with this edema surrounding the plantar portion of the ligament. Here's one more Lisfranc, this time a patient who was hit while riding his bike by an SUV. And on the plane radiographs here, we can start to see this ossific fragment along the tarsometatarsal joint. He promptly ended up getting an MRI image done as well, where we can see the fracture fragment with all of its edema and edema within the medial cuneiform as well. And this kind of floppy looking tarsometatarsal ligament, likely contused or sprained in the whole process of the injury as well. A couple weeks later, preoperatively, he got the CT, which now shows a slightly more well-corticated ossific fragment here in some kind of rounded off margins with the other portion of the medial cuneiform. And subsequently, he ended up with a post-operative MR, and this was after the fragment was removed. We can still see the sprain pattern involving both the plantar and also the proper portions of the Lisfranc ligaments. So I'm gonna just make a small plug for dual energy CT here. It is fraught with a lot of, badness in that, like, you can have a lot of artifact that can fool you. but this was a beautiful case of a Lisfranc injury and shown highlighted here in green as the areas of bone marrow edema. It kind of clues you in. I think we already knew that there was going to be something wrong just from the radiographic examination with the offset of the first metatarsal and also the second and third metatarsal. Seen nicely here with the fractures on the axial still image. But again, seeing the CT is showing us that, that radiograph is just the tip of the iceberg with all of these fracture fragments. We see even more at the base of the first metatarsal and even at the lateral margin of the lateral cuneiform as well. So always just have a low threshold to go to CT to look for those additional injuries. So here's our next case. This is a patient who fell, and the question is whether or not this is a Lisfranc fracture dislocation. You can see this fracture at the base of the fifth metatarsal, and I think the way I worded it is good. So I led you to the right answer. So this is false, and we got 100%. All right, so this is an example of a Peroneus longus tendon avulsion fracture. Here on the radiographic examination, we see this ossific fragment and then an additional fracture extending through the base of the first metatarsal. And then the CT images here nicely shows the fracture fragment. It's this like small triangle and some additional fracture fragments here. And if we window into that soft tissue window, we can start to appreciate that the Peroneus longus tendon is actually still attached to the plantar aspect of this base of the first metatarsal. So it's a beautiful case of an avulsion from that Peroneus longus tendon. All right, brings us to this next case. And this injury is caused by, so here's this small ossific fragment along the lateral margin of the calcaneus. We have a couple choices here: avulsion of the bifurcate, avulsion of the calcaneal cuboid, avulsion of the extensor digitorum brevis, and the calcaneal fibular ligament, or none of the above. All right, we've got calcaneal fibular ligament, extensor digitorum brevis. All right, and 13, oh gosh, the peer pressure, man. All right, so avulsion of the calcaneal cuboid, digitorum. All right, so are you guys ready for the answer? We're gonna go. All right, so the right answer was actually avulsion of the calcaneal cuboid ligament. And we're going to see why. So here's an example of an extensor digitorum brevis muscle from the literature. And I believe this was, sorry, I forgot to put the reference here. It's Dr. Yu's article. And you'll see that the fracture fragment for the extensor digitorum brevis tends to be a little bit larger. And on these oblique and AP images, they tend to overlap the calcaneus a little bit more. So those are some key findings to help you differentiate between these, this and the calcaneal cuboid avulsion injuries. The other answer that gained a lot of popularity was, I'm so sorry, that is my Google talking to me at the same time. The avulsion of the calcaneal fibular ligament is seen here, and you'll notice that this one is just like a slight fleck. And on your AP images, it's going to be located much more posterior to the calcaneal cuboid ligament injuries. Because remember, the calcaneal cuboid ligament injury is going to be right at that joint line, whereas the calcaneal fibular ligament is going to be attaching much more posteriorly. So look out for those to help you kind of define those differences. So here's our case one more time. Here's the cuboid, here's the calcaneus, and this is typically as a result of a kind of an inversion type injury where the capsule gets stripped off and pulls off a tiny piece of bone. Sometimes it's associated with some compression along that medial arch of the foot. This particular patient fell down a set of stairs at the zoo. All right. And brings us to this kind of concept of the Chopart joint injuries. And this is the Chopart joint, basically separating the talus from the navicular and the calcaneus from the cuboid. So you may remember this Sima line or this wave. It means wave in Greek. I am not well versed in Greek. I should have deferred to Soterius, but this is an example of intact Sima lines, whereas this on this particular patient is a disrupted Sima line. And not only do we see this avulsion from the talonavicular joint, the other half of that was that calcaneal cuboid avulsion fracture as well. So that same patient. One more patient here showing another Chopart joint fracture here now with multiple ossific fragments seen along the lateral margin of that calcaneal cuboid joint. And fortunately for our dual energy CT, it also picked up a little bit of marrow edema in there. Not that we would have missed that on the source images. Moving along to talk about some calcaneal anatomy. The calcaneus and the talus are very, very complicated. So I put in these slides in here just to kind of review the anatomy. This is viewed from the side, showing you nicely the posterior subtalar joint and also the middle facet and anterior facets. And from the top here, this larger posterior facet. And remember that the middle facet is a little bit more medial to that anterior facet. And now viewed from the medial side, you can see the facets for the anterior, middle, and also the posterior talus. So this brings us to this next image here, which is a word cloud slide. So this is like free text. So the question is, what is the mechanism of injury? So what we see here is a so-called lateral, a sagittal image from a CT showing the fragmentation here of the anterior process. Oh, nobody's responding. Oh, rolled ankle. Okay, that's good. Ski. I was hoping this nobody can see you, so you can put anything. Great. Perfect. All right. So we've got a lot of answers here. And so I'm going to move on from that slide. So this is the answer is a bifurcate ligament avulsion, and this one is age indeterminate. So we can see that the corners of it are a little bit more rounded off than it would be in an acute setting. So typically, we saw a lot of the correct answers on that word cloud slide. Inversion and plantar flexion are the typical mode of injury for this bifurcate ligament. And this is in contradistinction to this other anterior process of the calcaneal fracture. You'll notice in this case that the fracture fragment is a little bit larger, and we can see that this can potentially be due to compression and impaction, a slightly different mechanism of injury, and as well as eversion and dorsiflexion. So this next case, this patient is a patient who stands a lot and is having foot pain. So a little bit of an eye test as well. Give it a few more minutes. Remember to compare side to side with your other metatarsals. Maybe. All right, perhaps this one is on, let's see the responses here. Oh gosh. So we've got a lot of responses here in the correct area. So here's the correct area. We see a little bit of periosteal thickening at that second metatarsal, the fourth metatarsal shaft, excuse me. And here at the very base, you start to see a transverse lucency as well. So here is an example of a stress fracture in a slightly different location. If we pay attention to the radiograph here, we'll notice that this is a standing radiograph, and you'll notice some alignment deformities as well, mainly the hallux valgus and also this metatarsus adductus, which actually transfers a lot of the weight of the foot into this lateral margin of the lateral column of the foot. So instead of expecting these stress fractures to occur in the second and third metatarsals, we're seeing this in the fourth metatarsal base in this patient. One more finding on her is that because of her altered biomechanics, not only do we see the edema and all the periosteal reaction in the fracture itself and the MR image, but diffuse edema within the cuneiform as well. And here is another cuneiform stress fracture in addition to her fourth metatarsal fracture. The next patient has a similar finding. I have to say is extremely hard to see, but there is actually a fracture here. It's a subtle lucency, much better visualized at the time of MR imaging with the edema and also periosteal reaction in the frank fracture line at the third metatarsal neck. This is more classic findings for a stress fracture. He also had a reactive intermetatarsal bursitis, possibly in part due to continuing to walk on it, despite the fact that it was fractured. A more atypical fracture here is the navicular fracture. This is a 14-year-old ballerina who had had a previous injury, kind of rested, and then went back to dancing. And we can nicely see the fracture through the navicular bone a little bit more laterally. Really, it's hard to see on the oblique radiograph and only seen on that frontal radiograph. Here's the corresponding MRI showing the fracture line again and the flagrant amounts of edema surrounding the fracture. So always be mindful to look at this navicular, especially in your kind of sport athletes and who are kind of pushing themselves. We're going to switch gears again to the talus, and just a reminder of the anatomy here. This is looking from the top and then looking from the bottom. We have these little bumps back here. This is the lateral tubercle and also the medial tubercle. And then the facets that from the inferior aspect correlating with the facets on the calcaneus as well. This is a nice example of a talar body fracture. Here we can see the frank disruption and the fracture line extending into the subtalar joint. If we look a little bit closely, we can see the lateral talar dome fracture as well. Not that we needed the dual energy CT here, but it is highlighted and the talar body fracture in green. We can just see, again, this fracture with the numerous fracture fragments, some extending into the tarsal sinus, and the appearance of the fracture lines extending into both the tibiotalar and also the subtalar joints. Another closer look at that talar dome osteochondral fracture. And then coming and rounding out the talus with the Snowboarder's fracture. And this is, it's the season right now, so I want you guys to be, mindful and looking out for these fractures. This is this almost shelf-like fracture that occurs along the lateral aspect of the talus, best seen on your frontal and potentially oblique radiographs. You can see this little lip of bone with the frank discontinuity, and some additional fracture fragments extending into the tarsal sinus here. This is the last of the talar fractures that I'll show you, a little bit more subtle. I pointed out the little tubercles on the talus before, and there are two main tubercles, the medial and the lateral. And when the medial posterior tubercle is fractured, it's referred to as a Sedell fracture. And this is a fracture that might be potentially easily confused for an ostrigonum that you may see on a day-to-day basis. But it's a little bit different. It has a little irregular margins. And, our radiologist's best friend again, here's the previous exam, which has no ossific fragment back there. And the corresponding CT here showing that fragment, now a little bit more well corticated because it's been a couple of weeks. And again, showing this nice Sidell's fracture. This, I'll make this the last case because we're running a little bit over. But this is a distraction of the os peroneum here. So when we see this, we have to remember where the os peroneum lives. And it is indeed within that Peroneus longus, as it kind of courses along that lateral margin of the calcaneus and then underneath the cuboid towards its attachment on the base of the first metatarsal. The T1 and fluid sensitive sagittal images here show the distracted bony fragment of the os peroneum here and the associated edema and abnormality within the Peroneus longus tendon. So here you can see the tendinosis and the intrasubstance tearing within that Peroneus longus and the flagrant amounts of peroneal tenosynovitis as well. So this is the case I'll leave you with. I don't think anyone would miss this as a fracture, but this is a talar dislocation seen here with associated additional fractures in the distal fibula. And the talus is here displaced on his corresponding CT. It was important to note that the talar head itself was kind of bisected here with this intra-articular extension into the navicular. Fortunately, he was seen by the surgeons really, really quickly, and they underwent closed reduction. These are the post-reduction images, which are quite amazing because it looks like nothing has really happened. But I want to remind you that these are fraught with potential complications, the biggest of which is going to be the avascular necrosis, as we've disrupted the blood supply of the talus. So remember your cardinal rules and use your helpful habits. Always look out for that Lisfranc fracture and these smaller avulsion fractures. And if you're imaging chronic foot pain, look out for those stress fractures. And always remember to have like a very low threshold to use cross-sectional imaging, whether it's CT or MRI. All right, I'm gonna send it back to you, Hillary.
Okay, wonderful, Karen. That was a whirlwind tour.
I know a lot to go over, and I'm glad that the pull everywhere was working, and you guys did a great job.
I just want to let the audience know that if you have any questions for Dr. Chen, you can put it in the chat box now. In the meantime, I know we're nearing the end of our time, but I have at least one question. I see that you've shown a lot of CTs on the Lisfranc injuries as well as MRI, and you do the dual energy for the bone marrow edema. I don't have that capability, so I haven't played with that. But do you have a standard approach to cross-sectional imaging after you either see the tip of the iceberg kind of an injury on the conventional radiographs, or you may see nothing but clinically suspect a Lisfranc injury, particularly those low energy Lisfranc injuries that are notoriously subtle or occult on plain films? Do you then go to CT or MRI?
We're typically going directly to CT just because it's easy. They're already in-house. They don't have to wait for an appointment. Our backlog for MRI is much, much longer. Just because it takes so much longer to image. So
do you think they're complementary, or do they really provide the same information?
I think they're complementary because with CT you're kind of inferring the ligamentous injury, whereas with MR you're directly imaging it. So I find that if we are in the acute setting, say you have urgent care or in the ER, we're going to just move straight to CT right away if there's even any question. Oftentimes, if the patient can't bear weight, your first exam is going to be that non-weight bearing radiograph. If they're still suspicious enough, we'll just go directly to CT. With the bone marrow edema, the dual energy CT, I have seen definitely some problems where, I've definitely called, suspect Lisfranc injuries and been wrong. So I think it's definitely a developing technology that we're starting to use, and kind of seeing some of the pitfalls of. I know it's been around for a while, but we just started playing with it maybe about 3 or 4 years ago.
I have one more question. I know you have a particular interest in the musculoskeletal ultrasound, and I dabble in it too. And you had that beautiful case of the stripped superior peroneal retinaculum off the lateral fibula, and it was just so subtle on the MRI, and I mean, but the ultrasound shows that the peroneal tendons can sublux or even dislocate, but that was with the circumduction. So, I mean, do you routinely, if you see that kind of finding on the radiograph, will you recommend ultrasound? Or, I mean, it's an acute injury. There's so much hyperemia. If you're immobilized, it'll heal. Do you just reserve that if somebody's got persistent symptoms, maybe referable to the peroneals later?
Yeah, we're reserving that too. That I have to say, this was probably done a couple of weeks to months later. And I want you to also remember there is always a little bit of wiggle room. The peroneus longus and brevis will do a little bit of a do-si-do. Sorry.
Well, isn't that's you're talking about intra-sheath subluxation?
Yeah, intra-sheath subluxation, that's okay. But when it's kind of slowly moving out underneath that's when
pouch. It shouldn't have that pouch.
Yeah, so when it's heading towards the pouch, right about here, that's when I don't like it. So that with just the intra-sheath torsion, I'm okay with. But to answer your question, we're imaging these patients with ultrasound only if they have persistent problems.
Okie dokie. I see Patrick is thanking everybody for their attendance. So I think if there are no more questions, I don't see any more questions. I'm going to thank everybody for attending the webinar. Thank Dr. Chen for a fabulous, informative, and fun lecture. I want to remind everybody to take a moment to complete the brief evaluation. Patrick Kelly has provided that link in the chat.
I think there was one question from Dr. George. Can we access this later as well, please? I believe they're recorded, and they will be posted.
They're on the YouTube channel, the SSR Resident Education Club YouTube channel.
And many apologies, my Google's kept on trying to talk to us.
Well, that's what happens when you're popular.
Technology, and my son came in the middle of it too, so I apologize.
The dog is good.
All right, take care. Good night, everybody.